In hypercalcemia, the serum calcium concentration is greater than the upper limit of reference range, the normal range being 8.6 to 10.3 in milligrams per deciliter and 2.1 to 2.6 millimoles per liter. The pathophysiology of hypercalcemia revolves around an imbalance in calcium absorption, release from bone, and renal excretion. And all of this is regulated in the background by the parathyroid hormone. Causes can be categorized based on whether the parathyroid hormone is increased or decreased while in the presence of hypercalcemia. When the parathyroid is either normal or increased, it could be due to primary or tertiary hyperparathyroidism, lithium-induced hyperparathyroidism, and familial hypocalciuric hypercalcemia. It's important to note the differences between primary, secondary, and tertiary parathyroidism. Primary is when the parathyroid glands start producing increased amounts of parathyroid hormone independent of the serum calcium levels. Secondary is when it is a reactive increase in parathyroid hormone in response to a decreased calcium level in the blood. In cases where the secondary hyperparathyroidism becomes chronic, the parathyroid glands permanently start producing an increased amount of parathyroid hormone. This is known as tertiary hyperparathyroidism, and when the serum phosphate levels and alkaline phosphate levels are increased, tertiary hyperparathyroidism should be the leading differential. Now, in cases where there is hypercalcemia in the presence of low parathyroid hormone, the leading cause is generally malignancy. Other causes being increased vitamin D intake, thyrotoxicosis, Paget's disease, milk alkali syndrome, thiazide diuretics, and decreased glucocorticoid production. The clinical presentation of hypercalcemia can vary greatly, the symptoms being divided into general symptoms, neurological symptoms, and musculoskeletal ones. The general symptoms are fatigue, anorexia, nausea and vomiting, constipation, polyuria and polydipsia, and renal colic. The neurological symptoms being confusion, cognitive impairment, depression, and even coma. The musculoskeletal effects of hypercalcemia generally manifest as bone pain and muscle weakness. Complications of hypercalcemia can have significant implications. It can complicate into renal complications, GI complications, and cardiac complications. The renal complications are nephrolithiasis and nephrocalcinosis. The GI complications are peptic ulcer disease and pancreatitis. And the cardiac complications are arrhythmias and, in severe cases, even cardiac arrest. A fairly common phrase used to remember the symptoms and complications of hypercalcemia is painful bones, psychiatric moans, kidney stones, and abdominal groans. When diagnosing such a patient, clinical assessment is of paramount importance. We can get an ECG done, which will show bradycardia, AV block, and a decreased QT interval. Lab testing needs to be done to see the serum calcium levels, which will obviously be high, renal function tests, the parathyroid hormone levels, the vitamin D levels, plasma phosphate levels, alkaline phosphate levels, and 24-hour urine calcium levels. We can also use some imaging modalities like X-rays, CT scans, and myeloma scan to rule out the causes of the hypercalcemia. Management of hypercalcemia necessitates a multi-dimensional approach. We start off with aggressive rehydration with intravenous normal saline given at 2 to 4 liters per day. Bisphosphonates such as zoledronic acid or pamidronic acid inhibit bone resorption and lower calcium levels. And if the patient is still refractory, we give monoclonal antibodies like denosumab, which inhibits rank ligand and causes a decrease in osteoclastic resorption of bone. Thanks for watching, you guys. You can go check out more videos on the channel. Do leave a like and subscribe for more content like this. If you have any questions or suggestions, you can leave a comment down below. I'll see you next time.